Hello guys, today is the last lecture about the metformin, and today we are discussing the pharmacokinetics of the metformin, absorption, distribution, metabolism and elimination, pharmacogenomics, drug interactions, side effects, and most importantly, the clinical uses of metformin. Metformin is an oral drug. After administration in the GIT, it's partially absorbed. Let's suppose this enterocyte, okay, and when metformin reaches this area, it will transport it to the enterocyte through a carrier protein which is called organic cation transporter. Okay, here is a carrier protein which is called organic cation transporter, which passes the membrane 12 times and transports metformin from the lumen of the intestine into the enterocyte. Okay, this is what? Organic cation transporter, OCT. Which type? It's type 3. We have usually 3 types, type 1, type 2, and type 3. In the apical side of the intestine, we have OCT type 3, and metformin is entered the enterocyte. In the enterocyte, then it is diffused out through another carrier protein, which is called OCT type 1. This is the metformin. Enter the enterocyte, intestinal side cells, and then goes to the interstitial fluid. After that, the metformin diffuses out into the liver. In the liver, where it's the main target for metformin action, metformin is uptaken by OCT1 again. This is what? Organic cation transporter. And after exerting its action on the electron transport chain, inhibiting the complex 1 and reducing the cellular level of ATP and increasing AMP, metformin finally should leave the hepatocyte, and this time pass through another carrier protein, which is called mate carrier protein. MATE stands for what? Multi-drug and toxin extrusion type 1. MATE type 1. So the metformin absorbed from the intestine by a carrier protein which is called OCT3 in a facilitated diffusion way, and then passes through the OCT1 into the interstitial fluid, then the portal vein, and goes to the liver through what? OCT1 again, and possibly OCT3, but sorry, most importantly OCT1, and then leaves the hepatocyte through the MATE multi-drug and toxin extrusion 1. Then the drug goes to the where? To the circulation. Let's say what this is the circulation. In the circulation, metformin has a half-life of about 4 to 6 hours. Okay, and metformin is not completely absorbed from the intestine. It has an availability of about 50 to 80%. The bioavailability of the metformin is about 50 to 80%. Okay, then the metformin distributed into 3 main tissue. The first one, intestine, which is absorbed, then the liver, and also the kidney. Why only these 3 tissues are the main targets for metformin? Because only these tissues, the intestine, the liver, and the kidney, are rich in organic cation transporters. Organic cation transporter is highly expressed in this tissue, in the liver, intestine, and in the kidney. In the kidney, Metformin goes to the kidney, and let's suppose this is a cell in the nephrons. From the circulation, metformin transported to this cell again through the organic cation transporter. But this time in the kidney, we don't have OCT type 3 or type 1, we have OCT type 2, organic cation transporter type 2. This is the OCT type 2. And then the drug is secreted into the apical side. This is the basolateral side, and this is the apical side of the nephron in the proximal convoluted tube. And here you have what? You have another transporter. And this transporter is called what? MATE1. Just like the MATE1 present in where? In the liver, or MATE2. Multidrug and toxin extrusion type 1 and type 2. So the metformin passes from the circulation into the epithelial cells of the proximal convoluted tube. The uptake is mediated through the OCT2, and then they are secreted into the lumen through what? MATE1 or MATE2, and pass through what? Through the urine. Okay? So metformin is excreted through the kidney because it's not metabolized in the liver or in any other tissue. So after remaining in the circulation with a half-life of about 4 to 6 hours, metformin should be excreted through the MATE1 and MATE2 by active tubular secretion in the proximal convoluted tube. This is the proximal convoluted tubule, and excreted through the urine. Why you mentioned that transporters OCT3, OCT1, OCT2, and MATE? Because they are clinically somewhat important. First of all, they are important in cases of drug interactions. Any drug that competes with metformin to these transporters will alter the level of metformin in the circulation. For example, the first drugs that you can mention are PPIs, proton pump inhibitors, like omeprazole. Omeprazole or any other PPIs will compete with the metformin in OCT3, OCT1, and also OCT2, and reduce the metformin transportation through these carrier proteins. Another example of drug interaction is drugs compete for the MATE1 or MATE2 and reduce the metformin excretion through the kidney. For example, furosemide, okay, or cimetidine, H2 blocker, and also NAFLD, calcium channel blockers. These drugs inhibit this MATE or compete with metformin, so the metformin secretion from the proximal convoluted tube through the MATE1 and MATE2 will be reduced. Okay. Some other drugs, for example, imitinib or imatinib. Imatinib also inhibit metformin secretion in the proximal convoluted tube, and thus increase the metformin level in the circulation, right? And some antidiabetic drugs, for example, rosiglitazone, also Hypoglycemic. Rosiglitazone and Hypoglycemic are able to compete with metformin in the OCT1, and this transporter will be less permeable to what? To the metformin. So metformin uptake into the liver will be reduced, and metformin efficacy also will be reduced. Okay. And also, one more important drug interaction or drug, the metformin interaction with what? With iodinated radiologic contrast. Metformin. This iodinated contrast is used in radiographic studies, for example, in CT scan or angiography, and this contrast usually impair the renal function temporarily. Okay, and this metformin excretion through the kidney will be reduced, so metformin may accumulate in the circulation, and this leads to increased metformin efficacy, but at the same time metformin side effects, especially lactic acidosis. So the metformin in these patients who take the iodinated contrast, metformin should be stopped before the procedure and restarted at least 2 days after confirmation of normal renal function. Okay, that's the main drug interactions for the metformin, PPI, furosemide, imatinib, and also rosiglitazone and ripaglinide, usually by altering the transportation of the metformin through the membranes, either in the intestine, in the liver, or in the kidney, and this leads to altering the metformin efficacy, either increasing its efficacy or decreasing, altering metformin pharmacokinetics, and also metformin side effects. Okay, now we can talk about the pharmacogenomics. Pharmacogenomics is defined as genetic or genomic effects on the drug response. Actually, it's a new science, and it's a combination of the pharmacology with genomics and with the genetic polymorphism of the proteins in relation to drug response. For example, polymorphism of the OCT1 in some people, due to some genetic variants, OCT1 will be less permeable to the metformin, so the metformin efficacy will be reduced. And if there's some variants in the genes encodes for the MATE1 or MATE2 proteins, the metformin will be accumulated in the circulation, and the risk of toxicity will be increased or decreased? Increased, right? That's why you may see that some patients are more responsive to metformin while others are less. Metformin has more side effects in some patients, and in some patients it has no or very little side effects. This is due to genetic polymorphism, or call it pharmacogenomics. That's all about the pharmacokinetics and the drug interactions. Now we can focus on metformin side effects. Generally, metformin is a safe drug, but it also has some side effects. Because the drug is not completely absorbed and the bioavailability is about 50 to 80%, right? The drug is metformin is not completely absorbed, so the luminal concentration of the metformin will be high in the intestine. So it's logical for metformin to have gastrointestinal side effects. These side effects include, starting from the mouth, metallic taste, GI tract side effects. These include metallic taste, nausea, vomiting, abdominal pain or discomfort, then we have diarrhea, anorexia, loss of appetite, and also bloating. Generally, these are the side effects, GI tract side effects of the metformin: metallic taste, nausea, vomiting, diarrhea, anorexia, and also abdominal pain with bloating. As I said, it's logical for metformin to have GIT side effects because it remains in high concentration in the intestine and in the lumen of the intestine. And possible mechanism for the metformin's induced GI tract intolerance, it may be first, increased serotonergic effect. Serotonin is associated with increased GI motility and nausea, vomiting, and also diarrhea. Metformin is structurally somewhat similar to serotonin receptor agonists and may act on the serotonin receptors on increased serotonin level in the intestine and leads to these side effects. The second one, it has been shown that metformin inhibits an enzyme, increase histamine activity. Histamine is usually break down by an enzyme. This is the histamine. This histamine is break down into inactive metabolites. By an enzyme which is called diamine oxidase. But metformin inhibits the action of this enzyme, so histamine will not be converted into inactive metabolites. Histamine will be remained intact in the intestine, and also histamine is associated with increased GI motility and nausea, vomiting, and also diarrhea. The most important side effect of metformin is GI tract intolerance, which occur in about 12% of all patients when you start the metformin. The side effects are usually mild and transient, resolve with time, but in some patients, they discontinue the drug due to persistent diarrhea. About 3 to 5 patients on metformin eventually will discontinue on the drug due to persistent diarrhea. And the side effects can be reduced by starting a low dose of metformin and eventually titrating into the maximum tolerated dose. The second important mechanism of side effect of metformin is this is the first one. The second one is metformin induced vitamin B12 deficiency. Vitamin B12 is present in the foods. After ingesting, it will release it from the foods and bind with what? With a protein. B12 deficiency can be seen in patients on metformin. B12 in the stomach will bind with another protein called intrinsic factor. B12 plus intrinsic factor form a complex, and this complex then in the terminal ileum absorbed by a calcium dependent mechanism. The B12 and the intrinsic factor, depending on the calcium present, are absorbed by endocytosis. Metformin impair absorption of the B12 in the terminal ileum and with time reduce the B12 concentration in the blood. The side effects will not occur at the early course of the treatment, but it can be seen months to years after starting the metformin because the liver is usually rich in B12. The liver is able to store the vitamin B12 for years, for 1 year or 2 years, and even more. Okay, so B12 deficiency can be seen in patients on metformin. So the periodic screening for B12 deficiency are important, especially in patients on metformin, have diabetes, and also develop peripheral neuropathy. B12 deficiency leads patients to demyelination of large nerve fibers in the spinal cord, and they develop peripheral neuropathy. And one more complication of the B12 deficiency is macrocytic anemia. Because B12 is essential for the fully formation and maturation of the red blood cells, without B12 we may see macrocytic anemia and also peripheral neuropathy. So in any diabetes patient on metformin, if you have this conditions, you should investigate more for B12 levels in the blood. And this can be prevented maybe with supplemental calcium or B12 in small doses, okay? These are for what? Prevention. Okay. One more side effect of metformin, which is a very rare side effect, but serious, is what? Third one is lactic acidosis. Normally, glucose is used for energy in the muscle cells and use oxygen to this utilization, okay? Only two tissues in the body may use glucose without oxygen. The first one is red blood cells, and the second one is exercising muscle. Glucose is converted into what? Glucose converted into pyruvic acid, right? And this pyruvic acid then enters the Krebs cycle, electron transport chain, and produce what? ATP. But when metformin is present, especially in the liver and intestine, when metformin reaches high concentration in these two tissues, the electron transport chain is blocked. The Krebs cycle is also slowed down. So the glycolysis for conversion of glucose into pyruvic acid will continue, but the pyruvic acid will accumulate inside the cell. So pyruvic acid cannot enter the Krebs cycle or further to electron transport chain. Instead, it's converted into another product which is called lactic acid. Okay? Lactic acid normally produced from the RBC and exercising muscle, but in patients on metformin, lactic acid production is also increased from the liver and also in the enterocytes. This lactic acid then converted into what? Or it's actually a lactate plus hydrogen. The lactate can be used in some tissue, for example in the heart, for energy, but this lactate is mostly metabolized in the liver as a precursor for gluconeogenesis. At the same time, gluconeogenesis is inhibited by the metformin, so the lactate metabolism is also inhibited. At the same time, lactic production increases. Metformin increases lactic acid production and decrease or inhibiting lactic acid clearance. So the lactic acid accumulates in the body, and at the same time hydrogen ions. Hydrogen ions reduce the blood pH and cause acidosis. So lactic acidosis is characterized by what? First one, hyperlactemia. Second, low pH. And low pH means what? Acidosis. Okay, low pH acidosis and also electrolyte disturbance. So metformin By increasing lactic acid production and inhibiting lactic acid clearance or metabolism leads to accumulation of the lactic acid, hyperlactemia, also increase the concentration of the hydrogen ions, protons, low pH, and also electrolyte disturbance. And signs and symptoms are non-specifically to metabolic acidosis, including nausea, vomiting, signs and symptoms, nausea and vomiting, also hyperventilation, and also altered level of what? Consciousness. So, lactic acidosis is a rare side effect of metformin, usually occur in about 3 cases per 100,000 patients on metformin. So it's a very, very rare side effect of metformin, but usually fatal. About 50% of the patients with lactic acidosis will die, okay? So it's better to avoid lactic. So can we prevent the lactic acidosis? Yes, only by careful selection of patients. Any patients with risk factors for lactic acidosis should not be prescribed metformin. And these patients include those who have severe kidney disease, usually GFR, glomerular filtration rate, below or equal to 30, metformin is contraindicated. Or if GFR is below 45, metformin is not recommended, and if used, the dose should be reduced. Patients with liver disease, severe liver disease, or cardiorespiratory disease, cardiorespiratory insufficiency, alcoholic patients, alcoholism, either acute, excessive acute or chronic alcohol intake, and any other forms of hypoxia. Also, patients with type 1 diabetes mellitus, type 1 diabetes mellitus DM, and also diabetic ketoacidosis. These groups of patients are at high risk for lactic acidosis due to accumulation of the lactate. In kidney disease, the metformin will accumulate and the lactate excretion will be reduced. The liver is same, and also in hypoxia status, and also alcoholic patients, the lactic production and also metabolism is reduced. And also metformin at the same time leads to the accumulation of the lactic acid, and this makes the development of lactic acidosis easier, right? And if any patient with metformin develops lactic acidosis, it should be treated with prompt hemodialysis. The good news is that metformin is highly dialysable and can be hemodialysis can be used for removing excess metformin and also the acidosis, okay, with supportive cares, right? There should be a question that metformin will cause hypoglycemia or not. Metformin at therapeutic doses will not cause hypoglycemia, and metformin is usually called weight neutral or reduced weight. Weight gain is not associated with metformin. And because metformin is not causing hypoglycemia, it's usually described as what? Euglycemic or anti-hyperglycemic. Generally talking, metformin is not called hypoglycemic agent because it will not cause hypoglycemia at therapeutic doses, because metformin will not increase the insulin secretion or not acting on the insulin receptors. So metformin is called an euglycemic or anti-hyperglycemic agent. Finally, we can focus on the metformin clinical uses. Okay. What's the main indication for metformin? Of course, is type 2 diabetes mellitus. Type 2 diabetes mellitus is usually characterized by insulin resistance and marked gluconeogenesis increased. Gluconeogenesis is markedly increased in type 2 diabetes mellitus. So metformin inhibits the gluconeogenesis, and that's the main mechanism of action for metformin in reducing blood glucose. Okay. The first indication for metformin is what? Type 2 diabetes mellitus. In type 2 diabetes mellitus, metformin improves glycemic control in 3 ways. Improve glycemic control. First of all, metformin reduces fasting blood glucose. Lowers what? Fasting blood or plasma glucose. Secondly, metformin also inhibits postprandial spikes in glucose. Reduce postprandial after the meals glucose. Postprandial hyperglycemia. And most importantly, metformin lowers the HbA1c. HbA1c on metformin should be lowered. HbA1c is actually a fraction of the hemoglobin. It's called glycated hemoglobin. It means the hemoglobin is glycated with what? With glucose. This HbA1c is a good marker for the glucose control over the past few months, 1 month to 3 months, and it can indicate the glucose control over that period. Metformin lowers the HbA1c in about 1 to 2%. HbA1c, which is measured in percentages, is lowered by 1 to 2%. And it is a very, very good result for type 2 diabetes patients. Very few drugs are available currently to lower the HbA1c to that extent. Okay, so metformin improves glycemic control by lowering fasting blood glucose, postprandial hyperglycemia, and also HbA1c. Secondly, metformin improve the lipid profile. Most importantly, lowers what? Triglycerides. Triglycerols should be lowered. Also, LDL, low density lipoprotein, and also VLDL. Both are reduced in cases of metformin use. Of course, a slight effect on this. Most importantly is what? Triglyceride. And metformin in some patients may slightly increase the HDL, high density lipoprotein. And finally, the total cholesterol is lowered. Okay. Also, metformin, we can say, improve the outcomes of patients with type 2 diabetes mellitus. Metformin reduces the incidence or severity of the microvascular complication and macrovascular complications. Microvascular complications and also macrovascular vascular. Usually diabetes type 2 will not kill the patient, but the complications of the diabetes will eventually kill the patient. Macrovascular complications including what? Myocardial infarction, MI, and also stroke, and maybe claudication or ischemia of the periphery. And microvascular complications including diabetic retinopathy, nephropathy, peripheral neuropathy, and also autonomic neuropathy. Metformin reduces or at least delay the development of the microvascular and also macrovascular complications of the diabetes mellitus type 2. Metformin currently is recommended to be started at the onset of the diagnosis of type 2 diabetes mellitus, and the metformin dose is usually between 500 milligrams into 2 grams. It's usually the maximal dose of metformin. Beyond this dose, metformin is usually not more effective. Okay. Second indication before that, metformin can be used for type 1 diabetes mellitus? No, because metformin in type 1 diabetes mellitus is less effective, and also there is a high risk for metabolic acidosis. Already, patients with type 1 diabetes mellitus are at risk for developing diabetes ketoacidosis, and metformin increases the chances for lactic acidosis. So these patients are in a high risk for developing the metabolic acidosis. So metformin is not used in type 1 diabetes mellitus. The cornerstone therapy for the type 1 diabetes mellitus is insulin therapy. The second indication for metformin maybe what? Prediabetes. Prediabetes is usually defined as the period before developing overt type 2 diabetes mellitus. In this stage, the fasting blood glucose is usually between 100 to 125 milligrams per deciliter. These patients are at high risk for developing overt diabetes. Metformin sometimes can be used in these patients at least to delay the progression to what? Overt diabetes mellitus. And another indication for metformin maybe PCOS. Do you know PCOS? Polycystic ovarian syndrome, polycystic ovarian syndrome. PCOS is characterized by multiple cysts in the ovaries with insulin resistance. Okay, multiple cysts in the ovaries, insulin resistance, also androgen excess with resulting what? Hirsutism. And impaired ovulation leads to what? Less chances of conception. Either anovulation or oligoovulation. It means less frequent ovulations. Less frequent ovulations is linked to what? Less chances of conception. So one of the problems in the PCOS is insulin resistance. And metformin, from the previous lecture, we learned how the metformin improves the tissue sensitivity to insulin. So in these cases, in PCOS, metformin may be used to improve the insulin resistance. Also, it was shown that metformin reduced the androgens and improve hirsutism. Okay, and finally, it will increase the rates of ovulation and leads to increase the chance for conception. Other potential uses for metformin maybe sometimes can be used in Gestational diabetes. Diabetes during pregnancy. However, currently, better options are available for metformin, but metformin is also one of the options. And maybe you said in non-alcoholic fatty liver disease. Also, sometimes used in some forms of premature puberty. So these are the main indications for metformin. Actually, the main indication for metformin is what? Type 2 diabetes mellitus, which is currently the first option, the drug of choice for type 2 diabetes mellitus, unless it's contraindicated by contraindication that we discussed before that. And other potential indications include prediabetes, PCOS, gestational diabetes, non-alcoholic fatty liver disease, and also premature puberty. That's all about the metformin, pharmacodynamics, and pharmacokinetics. Thank you.